Good afternoon and welcome to today's webinar entitled Jurisdictional Risk Assessments, Deep Dive into Methodology, organized by the Association of State and Territorial Health Officials. My name is Lindsay Laverty and I am a Senior Analyst in Public Health Preparedness at ASTHO, and I will serve as the facilitator for this call. I would like to thank everyone for joining us today to learn about CDC's risk-based funding pilot from some of your colleagues. And I would also like to thank CDC for sponsoring this webinar. I'd like to provide you with a little background on this project before we hear from our presenters. If you joined our previous webinar in June, you may have heard this already, but for those who are joining for the first time, I'll just review that again. In 2011, CDC launched a one-year risk-based funding pilot to accelerate the development of public health, medical, and behavioral health risk identification and reduction models, interventions that are proven to reduce risk, and promising practices that can inform the larger awardee community. This pilot was part of a broader risk-based funding pilot that is intended to provide additional funding to high-risk jurisdictions. Today's webinar will capture some of the information and knowledge garnered from the risk-based funding pilot. Our presenters will provide an in-depth look at the methodology they use to conduct their Jurisdictional Risk Assessment, or JRA. And as I mentioned, this is a follow-up webinar from ASTHO's June 9th webinar, in which a panel of speakers provided an overview of the methodology, applications, and lessons learned. And this session will build on that by focusing on more details specifically about methodology. And then after our presenters, there will be a Q&A session for you all to ask questions. So with that, I'd like to turn it over to our speakers, Carl Michaels, Coordinator of Preparedness Programs for the New Jersey Department of Health, and Lawrence Heidenberg, South Region Public Health and Healthcare Emergency Preparedness Coordinator, also with the New Jersey Department of Public Health. Carl and Lawrence?
Thank you, Lindsay. I'll start off. First and foremost, thank you all for coming to listen to us to speak today. We appreciate this wonderful opportunity to share what we think is a very effective method. Just for clarification, in the original invitation for this, I was accidentally listed as working for the Salem County Department of Emergency Services. I actually do work for the New Jersey Department of Health as a Regional Emergency Preparedness Coordinator. That's just my mailing address. But be that as it may, we are very pleased that we have the opportunity to speak to you and give you a chance to hear a method that worked for us. In this case, experience guided by intelligence. Carl?
Good afternoon, everyone. This is Carl Michaels. I'm the Coordinator of Preparedness Programs in the New Jersey Department of Health, and I manage our Public Health Emergency Preparedness Cooperative Agreement from the CDC. Go ahead, Larry. So just a bit of a quick history. As Lindsay mentioned, this was a pilot from 2011, and New Jersey was selected as one of those pilots because we're part of the Philadelphia MSA and the New York City MSA. So we're actually part of two different jurisdictions. 16 of our 21 counties in New Jersey fall into those two MSAs, so we decided to go with one statewide MSA involving every county in the state.
First of all, because we fall between two jurisdictions, of course, knowing the way life works, it couldn't be simple that they were both using the exact same model. Philadelphia took one approach to conduct their HVA, while New York City took another. We examined both tools, both of which had quite a bit to recommend toward them, but for our purposes, what fit our needs very simply was to take Philadelphia's model, which was created by Dr. Esther Chernak and the folks over at Drexel University, and we're most grateful for their assistance and guidance with this, and adapt it, taking certain pieces from New York as well, and create our own statewide HVA. This entire process was not easy. We were lucky. We were able to partner with the New Jersey State Police Office of Emergency Management and also the New Jersey Office of Homeland Security and Preparedness. Bringing these two partners on board was very helpful because while New York City was more of a data-driven model aligned with the Kaiser Permanente model for hospitals, and Philadelphia was more aligned with some of the other jurisdictions, though with an excellent, unique approach for them. Even with all of their great tools to assist us, we found that the partnerships we needed with the state emergency management and preparedness officials and experts really made a tremendous difference in how we were able to operate. We pulled together a lot of data. However, as you may have heard, data isn't everything. What data did we use? We used all 21 counties' current emergency management pre-existing HVAs. We pulled together statistics on each county's special needs population from census data and other data sources. We looked at the basic demographics for New Jersey population by county, which really did help us quite a bit because we are a very unique state. We have more roads per capita than anyone else, and yet we've got everything from extreme urban to unbelievably rural packed into a not huge state. And the demographics gave us quite a bit to be able to work with and help figure out how can we approach this. We got information from mental health and other specialized health resources. We were able to pull New Jersey's advanced life support EMS data. Now I specify the advanced life support data because New Jersey is unfortunately somewhat unique. We have near complete data for all ALS calls. However, the majority of BLS data is virtually non-existent because New Jersey's structure does not have the Department of Health regulating all BLS service provided in the state. It's a very unique hybrid system, and it presented challenges because we couldn't pull the majority of EMS data because it didn't exist. We were able to get data from all of the New Jersey hospitals. We were able to pull information about licensed physicians and primary care physicians as well.
These are just some of the additional data sets captured, ranging from in-state FEMA declarations to documented terrorist attacks within the United States using a 100-year look-back period as available. All of the data you see here was made available to the subject matter experts who participated in HBA workshops, which we'll discuss in greater detail on an upcoming slide.
Okay, statistics are a great tool, but they're not everything. There's a famous saying, there are lies, darn lies, and statistics. Unfortunately, that's true because, for example, there is a 100% correlation between a person having growing cancer and having a pulse. That's a correlation that is 100%. Unfortunately, it's not causality. Statistics don't tell the whole tale. Numbers just never speak for themselves. People speak, numbers lay there waiting for people to interpret them. So we had to take a different approach. Since our numbers were incomplete and we recognized that no one's numbers are likely to be the full answer. If it were, the entire world would be ruled by computers. It only feels that way right now. We took the approach that experience guided by intelligence had to take the lead. What do we mean in this case by intelligence? Intelligence is both in terms of rational, logical thinking and objective information. We blend the two together because while people make mistakes, so do statistics when improperly viewed as the complete answer. That was something we were not willing or interested in trying to see happen. We conducted 2 regional workshops, one for the northern half of the state and the second for the southern half. We had participants from emergency management, public health, healthcare facilities representatives, the healthcare associations representing many of the facilities. We had special and functional needs experts, mental health representatives, emergency medical services representatives, as well as our own department. Pulling all these together allowed us to share with them all of the other data that you've seen previously to come up with an experience and intelligent HVA. We were able to do this, but we also recognized that we needed to say, great, we've done it. It's not a one-time deal. We plan to repeat the HVA every 5 years or after a significant event. By doing this and combining the information together, we can have a dynamic HVA that will also show us, are we managing to be better prepared for some hazards than others, so that we could actually drive the priority of preparing for the hazards that were most likely to be severe for us.
So this slide is just an abbreviated timeline highlighting some of our key HVA activities. As you see, in January 2012, we completed the modification of the Drexel Philadelphia tool into the New Jersey model. Then before we conducted those 2 regional workshops, we conducted a pilot workshop just with one county, Salem County, in March of 2012. Then we had those 2 statewide workshops, which Larry mentioned, in April. And then we summarized all the findings and released our final report in March of 2013. It has been said that once is happenstance, twice is coincidence, and 3 times is a pattern. Events have shown, however, that while weather incidents appeared to be in the category of happenstance, back in April of 2012, when New Jersey examined our data and completed the HVA tool, it has now quickly moved to the status of a pattern for New Jersey. In a period of only 14 months, New Jersey was struck with Hurricane Irene, the derecho storm of June 2012, and then Superstorm Sandy in October 2012. These storms all affected significant sections of the population of New Jersey in ways never seen before. Additionally, Hurricane Joaquin of October 2015 also threatened to have a major impact on New Jersey. This major Category 3 storm veered out to sea at the very last moment. You'll see, prior to just a few years ago, it was 1960, 51 years ago, was Hurricane Donna, the most significant major storm in 51 years. And then right after Irene, we conducted our HVA assessment, so we really only had one big weather event. And you see the damage, 10 deaths during Irene and 37 deaths during Hurricane Sandy in New Jersey, with over $30 billion of damage.
Hurricane Irene and Sandy gave us a lot of information. Unfortunately, gave us a lot of feedback on how well did we do. Salem County scores, for example, showed that severe weather and flooding were their 4th and 5th priorities out of the 9 we made use of. Only 1 death was reported combined, and that was due to traveling despite a travel restriction being in place, something that is certainly regrettable, but I don't see how it could be considered preventable. Atlantic County had weather and flooding as their 1st and 2nd priorities, and they had mandatory evacuations for both hurricanes. Hudson County had scored flooding as their 2nd priority. Hurricane Irene brought minor flooding next to just an average, oh, we had a little flood, life happens. Hurricane Sandy, however, brought major flooding. It showed that Hudson County really did use their experience, guided by intelligence, to help figure out what's their priorities and where are they most likely to have problems. They did indeed show they were right.
With assistance from our county offices of emergency management and local and county health departments, again looking at 100 years of data and all pre-existing hazard assessments, New Jersey settled on the displayed list of 8 hazards which comprised our hazard and vulnerability assessment: flooding, foodborne outbreak, hazmat incidents, nuclear facility off-site release, pandemic, power outages, terrorism, which is the CBRNE, chemical, biological, radiological, nuclear events, and severe weather, excluding flooding. Because of the severities and unique concerns with flooding, we broke them out into 2 different categories.
The human mind is really best able to deal with information in chunks, with the optimal number being 7 plus or minus 2. Anything more than that becomes harder to comprehend and retain. That's why we really did try to break it down into just these categories. By trying not to overwhelm everyone, having 8 categories to deal with, it made it something that was achievable, retainable, workable, to make everyone really understand and be able to focus on what we were searching for. The overall big picture of how to do a risk-based hazard and vulnerability assessment, you have to look at a variety of things. And give me a moment here to try and, there we go. You've got aggregate vulnerable population score that we used. This is the basic idea of these folks are affected in ways that the general population is not, or affected more severely than the general population. We need to be able to account for that. Probability. How likely is something to actually occur? What is the human impact on it? What is the healthcare impact? What is the community impact? And what is the public health service impact? All of these things, these from probability through public health service impact, really define some of the severity and probability. We can account for that. We can adjust for the aggregate vulnerability, but you also have to adjust for how well are you prepared to be able to handle it, what assets do you have to bring to bear, and that's our preparedness score. One of the big things here to keep in mind is that just something as simple as English proficiency or lack thereof can be a significant barrier in dealing with communications for any risk. However, how significantly will the outcome for an individual vary based upon the hazard? If they don't speak English as the primary language, is that 100% of the time something that is going to make the impact for them worse? No, not necessarily. Certain hazards, yes, it will. Because things vary so much in this state, our English proficiency or lack thereof rate varies from everywhere from 8% to 56%. So different counties, different areas are going to be affected very differently. New Jersey has 565 municipalities. We exist in a home rule form of government and multi-tiered control over emergency medical services. A lot of the data that is available to a more centralized system, such as New York City, or with a capability to subcontract with a university such as Drexel, to gather this data, it proves to be easy. When you don't have that, you have to have a guide to assist subject matter experts in confirming or refuting their own experience and knowledge so they can arrive at a consensus to the answers. This tool that people filled out, they filled it out one packet for the entire county with all of the players discussing and bringing their subject matter expertise to bear on the problem. This really made things simpler and made things work much better because face-to-face interaction of the group was a key to the success. It's very easy to send out a survey and get a survey back from emergency management and one from public health and one from hospital A and one from hospital B, and put all of this stuff together and let a computer chew on it and come up with an answer. However, what made this work for us, and what I think is a key factor in the accuracy of this tool, is the fact that by having face-to-face discussions, it allowed for the opportunity for discussion and debate. It threw out information that a survey could never have captured and managed to change someone's mind when a particular person or group might feel, oh, it's a clear-cut and dried, weak changes in mental health. Oh, but did you ever consider these factors? Wow, you're right. half the people in the entire population are going to be affected. It makes a major change in how they scored the tool, and as a result, what the answers turned out truly to be.
History has shown that vulnerable populations have been adversely impacted by certain disasters. As Larry had mentioned, New Jersey tried to account for such by adjusting risk scores based upon the unique vulnerabilities of at-risk populations. The same as Philadelphia, New Jersey identified 9 populations to represent as at-risk groups. These 9 groups included hearing disability, vision disability, ambulatory disability, cognitive disability, limited English proficiency, poverty, chronic disease, which New Jersey defined as diabetes or asthma, children age 18 and under, and finally elderly age 65 and older.
Diabetics can have a chronic condition that requires appropriate long-term management, where the case of asthma will have both chronic and acute effects that, especially in some cases for CBRNE and pandemic hazards, may play a significant part in the group's excess vulnerability to a hazard. How did we end up adjusting for this? Based upon the answers, we looked at a score of 0 through 4, 0 representing 0% of the population will be affected unusually in this way as compared to the quote-unquote general population. A score of 1 represented more than 0% but less than 5%, so on, ranging up through 5 to 10, 10 to 15, and at least 15% of the population being affected here.
For probability, after reviewing available data, multidisciplinary teams of county level subject matter experts came to consensus, same way, using a Likert scale ranging from 0 to 4, 0 being improbable and 4 frequent, likely to occur annually. This certainly wasn't an exact science, but the process was definitely evidence-based. This slide isn't designed to scare anyone away who's afraid of math. It just illustrates one of the many formulas built into the HVA tool. So when examining the probability of terrorism or CBRNE events, to come up with a statewide score, the HVA tool calculates the sum of each county's probability factor multiplied by the percentage of the county's state population. So if Mercer County has 10% of New Jersey's population, it accounts for 10% of its probability score, nothing more than a simple weighted average. Preparedness may be low, severity may be high, more likely a mix. Some things can't be prepared for to prevent, but can be prepared for to respond. What you see here is the statewide rankings of our HVA garnered in 2012. New Jersey's overall planning priority scores are a proportional sum of the 21 counties. And our top 3 hazards identified were pandemic, followed by terrorism, and then severe weather. Again, this assessment was conducted pre-Sandy, and a repeat analysis is planned for the upcoming grant year.
Excuse me. This slide really just plots probability versus severity, adjusting for nothing else. The severity of, for example, a nuclear facility off-site radiation release is quite severe, but it's very low on the probability scale. Similarly, at the time that this study was done, it was felt that probability was quite high, but its severity couldn't be that bad because we had nothing to go by for experience nor for hard data. Things like terrorism and pandemic have both high severity and high probability. So these are things that must be taken into account. This is the case study for one county, Salem County, since they were our pilot project to test out and make sure that the tool actually worked. Based on their scores, their highest planning priority goes to hazardous materials. That's because they have a full 10% of the hazardous materials site for the entire state of New Jersey just located within their county. Things like pandemic were also very high, terrorism, weather excluding flooding and then flooding. It is also the location of 3 out of the 4 nuclear generating plants in the state. So for them, nuclear facility off-site release certainly could have a high severity. However, their probability is low and their preparedness is quite good. Power outages and food outbreaks. These are all things that applied specifically to Salem County, though they don't match up with the state's overall scores. That's okay. Each county is unique in New Jersey. There's nothing wrong with that. The thing that has to be kept in mind, though, is just as you can't say Salem County is wrong for having different priorities than the state has, similarly, you can't say that you're going to compare Salem County, which is a rural, poverty-stricken county, with Bergen County, which is in a more urban area and relatively well off compared to Salem County. Can you compare these two based on the planning priority score? They cannot be compared. It's not fair, and it would not be accurate.
One nice thing about the HBA process in New Jersey was that each county received their own assessment report, which ultimately rolled up into the state report. But for those listening to today's presentation, the tool can easily be adapted to cover a city, municipality, regional coalition, or any other desired geographic configuration. New Jersey's 3 goals for the ongoing HBA process were mitigation whenever possible to reduce both probability and severity, preparedness to respond effectively, and improving stakeholder coordination. We've learned from experience that while all emergencies begin at the local level, a collaborative response can make a difference between life and death. You have our contact information here. If you have questions in the future, I think we're going to take questions now. I'll turn it to Lindsay.
Thanks, Larry and Carl, for that great presentation. I would like to now open the phone lines for questions. So for anyone on the phone, if you would like to ask the presenters a question, please press *1 on your phone keypad, and we'll connect you.
There's also a link to the full HBA report, which you can get from the NJLM website.
And there are no phone questions at this time.
Okay. Well, I don't see any questions in the chat either. So I guess we can conclude early if there aren't any questions.
Someone just typed something in the chat.
Oh, okay. Okay, yes. So the presentation has been recorded and will be available on ASTHO's website in about 3 weeks. It'll have the full transcript and the PowerPoint and audio. So that will be available shortly.
Additionally, anyone who has any questions that they come up with after this or needs further information about how to adapt this tool is welcome to contact Carl or myself. We'll be happy to take any and all questions as they come here or in the future about this tool.
All right. Well, great. Thank you, Carl and Larry, again for sharing all of that information. And thank you, everyone, for being on the call today. And I hope you all have a great afternoon.
Thanks, everyone.
Thank you.